One. So, and we are live. So, happy Thursday, everybody. So, we're in the UK with me in Scotland, 7 p.m., but we're also in Canada with Shirin. So, this is Dr. Shirin. She is a fertility doctor, and we're doing this live tonight basically to help you guys with the questions that we get asked a lot about fertility, and we're going to be basing it around PCOS. But while we're doing that, I'm going to get Shirin just to come on and say, who she is and things. So I'm going to quickly go over to Facebook to make sure that I am live. So welcome, Shirin. How are you doing today?
Thank you. I'm doing well. Thank you for inviting me.
Yeah, honestly, this is going to be I'm really excited about this one. It's going to be really, really good for the women, and I can't wait. So how has your day been? But just if you let the women know just a bit about yourself and what is it you do?
Yeah, absolutely. So I am a fertility doctor here in Toronto, Ontario, Canada. So what that means is that I did training in obstetrics and gynecology for 5 years, and then I actually did a subspecialty fellowship in reproductive endocrinology and infertility, which is a fancy way of saying fertility medicine. And so now that's all I do. I just focus primarily on helping people to conceive.
That is, it's so good. So you'll be able to help women, in their darkest of time when they're really, really struggling. And it's quite an embarrassing problem for women to feel that they're not, there, why can't I get pregnant? And then feeling that they're not getting the help from the doctors. So this is really, I'm just changing the public settings on the live so everyone can watch it. That should be it. So this is why we wanted to do this live tonight with everyone, because Shirin, being that fertility doctor, we're going to go a few of the steps that, about BMI and just, what kind of help can we get here. So hold on a second and bring this up. So who do you find that actually comes to you for the help the most, Shirin?
Yeah, so I see people primarily who are struggling to conceive. I do see some people who are doing kind of a fertility check or who have questions about their fertility or what they can expect. But primarily, I see people who have been trying for several months with a partner to conceive. I also see people for fertility preservation, so who are thinking about egg freezing, sperm freezing, embryo freezing. People who are struggling with male factor infertility, endometriosis, adenomyosis, all that kind of group of people. And a big part of my population is certainly people who have PCOS, who have irregular cycles, who need a little bit of help with some ovulation induction. And then kind of related to all of this, I also see people who are struggling with pregnancy loss or recurrent pregnancy loss. Okay. Yeah, I would say that's like my general population of people.
Okay, so there's so many tangents I could have gone off there in my brain about trying to help women as well. So just one of them I'm going to go on just now that's not on your question. So sorry, I'm going to throw you under the bus a little bit. So do you find that a lot of women who come to you with PCOS are the ones also with the recurrent pregnancy loss and miscarriage? And what do you kind of find that is the issue, like vitamin D, or is it possibly their egg quality or, their lining because it's not optimal for PCOS?
Well, I would say overall, we know based on the literature that patients with PCOS can struggle with miscarriages, but we're not entirely sure what the reason is. So it could be any one of the things that you're describing, because all of those things have been linked to PCOS and the development. So things like low vitamin D, irregular cycles, which may lead to an inadequate luteal phase. There's some question about egg quality, like a question of earlier ovulation, immature eggs. Is that the reason behind things? But I would say we don't know the answers to a lot of those questions. I would say, like, in my practice, when I see people for recurrent pregnancy loss, I rarely find one thing that I can pin it on and say, this is PCOS and we're going to fix it through XYZ. More often than not, I can't actually find the reason why people are struggling with recurrent pregnancy loss. So I wouldn't actually say that I have a big population of people with PCOS and recurrent pregnancy loss.
Okay, no, that actually kind of maybe is going to be reassuring for the women as well. So it's just something that came to me when I've asked that question, because it's something that I've researched in the past, knowing that like vitamin D has a major impact in women with PCOS have low vitamin D levels. So there's always that correlation there. So, but yep, that's really, really reassuring to know. So I've just got one here, a question for you. And this is going to be one that a lot of the ladies that come to me for help, and especially ones that I I help even on TikTok and in the free group, is about the BMI. So that's your body mass index. So the question is, can you explain why the BMI is so important for fertility?
Yeah, I mean, it's challenging. I would say BMI as a specific entity is not the greatest measure of metabolic health, which is kind of, what its intended purpose was.
Yeah.
But the challenging part is when you are doing research, of which I do a fair amount of research, it's hard to study something if you don't have a way of standardizing the language across the world. And we're lucky because science is a language that, is spoken in many different countries, and it allows us to communicate worldwide. But to pick a language or to pick something that we can all use, that's how BMI kind of came into play. So I would say that that's one thing that makes it challenging when we're talking about kind of BMI and fertility, is that it's different when you're reading about it in a paper versus when you're actually explaining to somebody who's in front of you and has been given a BMI value, how it relates to their health and fertility. But from what we understand in the literature, unfortunately, a higher BMI is associated with lower fertility rates and higher miscarriage rates. Now, what elements of that, like, for example, is it that people who have poorer reproductive health related to metabolic syndrome are the ones who struggle with that? Is it that there is more inflammation? Is it higher estrogen levels in people who have higher central adiposity? There's so many other factors that haven't really been teased out from that literature about how BMI impacts fertility. Low BMI also impacts fertility in the same
It does, yes.
Miscarriages, lower chances of implantation. And so there is kind of like an optimal BMI category, but an optimal health. But I would still say we're still skirting around what that optimal health is and how do we get there. Sense.
Okay. That does actually make a lot of sense as well, but it's just, I know you're in Canada and you're in a fertility clinic, so it might not be the same where you are. So just excuse me if I'm wrong, but what I find mostly from the women who do come through me is about the BMI and about, I think they know why it's important, but it's the fact that they get sent away. They'll wait maybe a year or a few months for their appointment. They'll go in knowing that they're larger due to PCOS and they're not getting the help, but then they get told to go away. Just lose weight, just come back when you've lost 100 pounds, sort of say, or till you get into a BMI of, I think they've lowered it now to 30, I want to possibly say, but it could be lower than that. So I don't know. It's just about across the board. I think there's not that help that they're given. Is it? Do you find that, I'm not saying you, of course, like, because I did say to you, this isn't an attack. This, guys, this is not me like grilling Shirin. I promise you, it's trying to like get you guys the help so you can get the most out of your appointments as well when you go in. So if you know what to say and what the reason is behind it. So is there a little bit more why you can maybe talk about the BMI aspect, about, how women going in and they're just sent away with no other explanation?
Yeah, no, I hear you. And I hear these experiences quite commonly, and it's certainly disappointing to hear. But what I would say overall is that we do know there's two things that I know. One is that people who have a higher BMI or a higher weight, poor metabolic health, that is not related to PCOS, can struggle with menstrual cycle irregularities that can actually improve with a loss of 5 to 10% of weight. Similarly, patients who do have PCOS, it's the same thing. A loss of 5 to 10% of weight can actually improve cycle health outside of BMI. Although higher BMIs tend to impact when you don't have PCOS more than people with PCOS and higher BMI.
Yeah.
So all that means is that PCOS does not equal high weight, and higher weight does not equal PCOS. So they can be two separate entities, first of all. Yes. But we do know that for both, there is kind of what's called the first line treatment in my world and in my field, which is that it's quoted everywhere that we know 5 to 10% of weight being lost can resolve menstrual cycle health and menstrual cycle regularity. And so I think when that filters down through expertise through different doctors reading different guidelines without the same kind of knowledge of the nuance and all of that stuff behind a lot of these recommendations, it will come out that way, which is, well, the first line treatment is go home, try to lose weight for 3 months, and then come back and let's move to the second line treatment.
Okay.
So I would say that's probably where I think the disconnect maybe is.
Yes.
Because it is a thing, it is a treatment, and it is, as physicians, we should share that knowledge with people. That working on those things can be helpful. I just think it should be a tool in our armamentarium of what we have available to people. And sometimes in the medical world, it's not translated as a tool. It's translated as go do this first.
Yes, very much so. No, you've articulated that very well. So in fact, I hope a lot of the women watching are now knowing that maybe some of the doctors are not just saying, go and lose weight. It is just that that's what they've been sort of taught to do, and it's coming out maybe a little bit wrong. But then they're not realizing that. So yeah, so that makes complete sense. So we do have some more questions sort of surrounding this as well, though. So with the BMI, so I've lost my place here. So yeah, so what else can women do in the meantime, though, to help fertility, especially when they have PCOS? So after like the BMI, you know, they've been told to go away and lose some weight. So this is where the women get lost. They're like, yeah, what do I do? So what can the women do in the meantime?
Yeah, absolutely. So first, I should just mention, of course, that everything that we talk about here is not specific medical advice, but just for general education and medical education overall. So everything I say, if you want to know how it applies to you, I suggest you check in with a physician. Overall, when I think about people with PCOS, the things that they can work on at home are the things that truly everyone should be working on. It's just less prominent in people.
Yeah.
And that's what I tell people with PCOS is it's just a spectrum of normal. Health is just a spectrum of normal. Yeah. And unfortunately, they have something in which pushes them over on the spectrum of menstrual health a little bit further than some other people may. And so the things that in general people should be working on is a healthy, balanced diet, which means not restricting. So we're not cutting out carbs. We're trying to focus on more fruits and veggies. We're trying to have healthy fats. We're trying to have a good amount of protein. And these things are important for fertility, right? Restrictive diets, going to that kind of nutritional deficiencies end of things is also not good for when we think about supporting a pregnancy as well. And so finding a balance with that respect. Exercise is great for everybody's health, really. Like we should all be engaging in strength and cardio training. It's not specific to people who have an elevated weight or PCOS. Health, sleep has been linked to a lot of reproductive health. And so finding what works for you in terms of your sleep hygiene, making sure that you're getting 7 to 9 hours of sleep or what makes sense for you. Some people are on the lower end or the higher end of that spectrum. Stress reduction as much as possible, which doesn't mean quit your job, leave your marriage, etc. But what it means is thinking about how you cope with stress and coming up with healthy coping strategies for yourself so that you're kind of having a reset. You're not veering onto the burnout area because we know stress impacts health as well. Yes. And so those are kind of the things that I talk to people about overall in terms of supporting their overall health, which will in turn support their fertility as well.
Brilliant. So you've basically just sort of told everyone what I teach everyone. So I'm very glad about that because, guys, we've not had a conflab or anything before we've come on here. So we are in agreement totally about how to better your lifestyle and get yourself into that position after you've been told to go away to lose weight. And it does work. By the way, guys, it really does work for doing that. So, right, the next one would be what does an optimal, right, this is sort of moving on again now. So what does an optimal cycle look like for when you're dealing with fertility? So what is, if a woman came in and she had the perfect cycle on paper, what does that look like?
Yeah, so I would say that really, when we think about a menstrual cycle, we know that the luteal phase, which is the phase after ovulation, is generally fixed. And that's the time when the lining is being prepared to accept a fertilized egg to grow into an embryo. And so that generally is about 13 to 15 days.
Yeah.
So that would be optimal in terms of the luteal phase. The follicular phase, which is the phase right before that, before ovulation and ends at ovulation, is the growth of the follicle. And that really varies. And what we see is that people can have a variation of a total cycle length of 21 days to 35 days, and that's considered within the sphere of normal.
Yeah.
I do have many people who have very short cycles, like up on that 21 days, and it feels like it's very fast, but they're still able to conceive. So it's not so much, I would say that range seems like big to people because people are used to hearing kind of 28 to 32 days.
Yes.
But I would say that in general, we talk about 21 to 35 being normal.
Okay, good. And what would you say is an optimal period? What does that look like to you? Because this is what I help teach to women, and I help women have healthier cycles. You know, typically someone will come to me and they've got really heavy periods and they've got very large clots, you know, resemble bits of liver, or opposingly, they'll have very little bleeding, maybe 1 or 2 days scanty bleeding. And, you know, this, in my opinion, is not healthy. So what is a healthy period that the women should be looking for?
Yeah, so I mean, I would say overall, when we think about what a normal period is, it generally ranges from 2 to 7 days.
Yeah.
And on the heaviest days, people generally change their tampon or their pad 4 to 5 times a day, and that would be fairly normal.
Sure.
But I would say I'm less concerned about light periods. They don't really mean anything to me in terms of the amount of bleeding.
Okay.
Unless people have had previous surgery, unless I'm looking for scar tissue or something like that, I actually am not particularly worried about it. I've also noticed people are worried that it means their lining is thin, and that's not correlated.
Okay.
So I would say I'm less concerned about that.
Mm-hmm.
Heavier periods I am concerned with, and more so from the sign that it could be some other pathology. There's a reason that the cycles are heavy, either an anatomic reason, either a hormonal reason, it's PCOS, it could be malignancy. There are things that heavier period is more concerning. And I would say the other thing I've noticed people are concerned about is the formation of clots. It's not actually the clots themselves that are worrisome. It's just that the amount of bleeding. So the clots it's a good thing to clot. It means that your body is capable of stopping the flow of blood. But it would just be the volume of everything together, whether it's bright red blood or clotting, because clots just form because it's been some time since the bleeding has happened.
Yes.
So I would say overall, it's just the higher volume of blood that I investigate.
Okay, cool. Because the reason I'm asking, because a lot of women, that was me until I was 35. I'm 43 now. I mean, I went through life not even knowing what a period. It was like, oh, I'm bleeding. What does that mean? You know, we didn't know anything about hormones. And again, this is another topic. It's not for today, but women are not taught about what is a healthy period, what is normal, what should they be feeling. And I feel that is something that's really good to hit home to women, of what they're feeling. So just if it can go a little bit is to like reassure them of what they're experiencing is maybe a normal period, or they have to go towards trying to help that period somehow. So that was a really good answer, Shirin. Thank you. Okay, so this is sort of one that I work, this is sort of because you're the medical doctor, this is how it's good to speak to from like my point of view to other people in different fields, like medical doctors and people with other specialities I deal with on the natural side. So do you advise any natural supplements to the women that can help?
Yeah, I mean, so the thing, of course, in Western medicine, the challenge that we have with supplementation is they're not regulated in the same way that pharmaceuticals are regulated. And so we don't know how much goes into them. And that also means that in our research world, it actually makes them very difficult to study. So I would say that's part of why medical doctors don't recommend a ton of supplements. But the ones that I do recommend, or I talk to people about based on the literature that I know, is vitamin D. We don't necessarily have to measure vitamin D levels, because the problem with measuring vitamin D is actually that the assays and the way that they're measured is not standardized. So really everyone should just be taking vitamin D overall between 1 to 4,000 units a day. to the other supplement that I typically recommend to people, and I do recommend measuring it, would be iron. So ferritin levels, finding out the level of that, because I find that most females are deficient in iron, and that can lead to symptoms even without actually having anemia or low hemoglobin.
Okay.
So that's another, iron supplementation is the other thing. There are studies on inositol in people with PCOS, similar to metformin. I prefer metformin only because it's a pharmaceutical, and so I know how much is going into it. But inositol is a reasonable alternative. The other ones that I'm a little less clear on, or that I don't study very often, would be the other one that's been starting to be described as berberine. Again, not a ton of stuff out there about it, and I would tell people that if they're trying to conceive, they should stop if they become pregnant. But another one that people describe as potentially working through that insulin resistance pathway if people are struggling with PCOS. Those are generally the supplements that I would recommend, and otherwise I recommend that everything. Oh, and if you're trying to conceive, folic acid, and that is for the prevention of neural tube defects. And so that's important for all the population I see. And then the last one is making sure that you have healthy fats in your diet, because those healthy fats give you a few things. They give you things like choline, they give you things like omega-3, DHA. And if you're not getting that through your diet, then a supplement can be helpful.
Okay, I agree. Everything that you've just said there. I don't talk about berberine hardly at all, actually. It's just because I like inositol better there. And it's just that my sort of hypothesis for PCOS, and if I was to do a research scientific study on it, that the amino acids, so there are a few amino acids I put together that is greatly, I'm not going to go into here, guys, because it'll take up too much time, but it's the amino acids profile. So that's like your NAC, L-carnitine, your L-glutamine, tyrosine. All of these have been so beneficial. So I was just interested to know if you were going to say any of those, but inositol absolutely is my number one. But just so we don't have to answer it at the end, just because we're talking about it now, we've had a question, is iron linked to low folate?
So the pathway is complicated between iron, folic acid, vitamin B12, but we can't actually measure folate or the amount of folate in the body. And so we don't specifically understand how to relate all those things together in the way that we measure them. And so I recommend supplementing them separately, but they are all related to the circulatory system and the way that we absorb different vitamins, and iron and folic acid are certainly related.
Yeah. Okay. And just one to come from me, I was actually quite a staunch believer before, after research about the methylated folate before, but I've now reverted back to, yes, do methylated folate, but also take folic acid for the neural tube defects for that. Is that something that you talk about at all?
Yeah, and I think, again, it goes back to our limitations in the way that we research things.
Yeah.
And we have to remember that Western medicine is all based on evidence, right? That's our whole thing, is that we study things and then we figure out how to advise people on things based on things that are studied. And the reason for that is because there were so many things done in the past that were not studied. And then when they were studied, they were not found to be effective. And I'm talking about things like, huge surgeries, debulking surgeries, removing the pectoralis muscle, et cetera, for stage 4 breast cancer. And after they studied it, they found it wasn't effective. And so they stopped doing that. And so I'm just giving you a bit of a background into an understanding of why Western medicine is so evidence-based, is because we really don't want to veer on the side of harming people. And so this goes into this concept of folic acid versus methylfolate. Now, I can understand the physiologic reasoning for why people feel that methylfolate is a better supplement. But my concern, again, focusing on evidence and as a Western medicine-based trained physician, folic acid is what was studied. And it was found that folic acid specifically reduces neural tube defects. So it makes it really hard for us to parse out who processes it properly, who needs the methylfolate version of it all. And so I agree with that approach, that to give both, because it's not harmful to take it in addition to that. But I would be concerned that it may be harmful not to take the folic acid, again, because of the evidence base that I'm familiar with.
Exactly. And they can't really do a lot of research on it, because it's quite unethical, because then you'd have to be risking harming some women who's pregnant, so for the risk of getting neural tube defects. So yeah, I get that. So it's just better taking them both. So it's just in case that was a question that did come up, guys, because it does come up a lot on TikTok for some reason. So yeah, that's helped you. Okay, so now moving on. So most women with PCOS actually struggle to ovulate. This is something that we know. So anovulatory cycles, and this can then cascade onto the other things with it. What would be your advice? I know, like, you can obviously state your non-medical thing, but what would be your advice for the women who are coming in to see you who are not ovulating, but probably without the medication, you know, the Clomid, letrozole? What would you say?
Yeah, absolutely. And so back again, none of this is specific medical advice. I just have to keep giving the disclaimer.
Yes.
But when I see people, it really depends to me what their age is and what their family goals are, because those are really important in terms of helping people understand the timeline for how long they can try things on their own versus when they may want to be more directed. And so for somebody who's in their later 20s to their early 30s, there's certainly time to think about different ways of doing things, going and trying some other strategies to get your cycles back, to get your ovulation back. But if you're in your later 30s and your early 40s, I talk to people about really thinking about being more directed with what their fertility goals are because of the impacts of age on fertility. So if I were seeing somebody in their later 20s, their early 30s, in terms of how to improve ovulation, it's all of those lifestyle things that we've already talked about as being really key for people with PCOS. And I talk again about how people are on this spectrum. And for somebody who doesn't have PCOS, I still advise all the same things. But for somebody with PCOS, it may help push them back towards that spectrum of what somebody else experiences. And it's hard because I think a lot of the people with PCOS express to me that they just want to be normal.
Yes.
Everything would go back to normal. And I try to help people understand that they are normal. Everybody's normal. And normal is a spectrum. And they're just on a different end of a spectrum. And they have to work harder at some of those things like diet, exercise, sleep, to bring them back to that area of normal menstrual cycles. Even in the people who for example, I recently had somebody who really didn't want to try any ovulation induction methods. I see in the chat here people are asking about letrozole and Clomid, and this person really didn't want to do those things, and so for a year worked on some other things. All the strategies she could think of, diet, exercise, was on supplements, inositol, all this stuff. And when she came back to me, her cycle still hadn't returned, which she was disappointed by. She felt she had done everything and they still weren't coming back. And I said, hopefully it will make you more responsive to the medication, because one of the aspects of things is that even if your cycles don't come back, sometimes the medications like letrozole and Clomid, the lower doses don't work unless you work on all those other things. And then we used the lowest dose of medication, she ovulated, and she's pregnant.
Oh, wow.
So,
okay.
Yeah. And now it's all okay, but it's not, you know what I mean? Like and it was probably all of the lifestyle stuff that she did that really did that. It wasn't, and the small dose of medication that we gave her to help her ovulate, it was the smallest dose, which may not have worked a year ago. So everything in combination, and that's how I tell people, like, it depends how much you want to work on this stuff, how long you would like to spend doing it, but it's not a failure if you still need a little bit of letrozole or Clomid to help you ovulate, because people with PCOS sometimes need a little bit of support in that way.
Yeah, I completely agree. And then from that patient you've had, maybe it's like they were doing everything, but you can't see what's going on inside. So what they might have been doing was lowering their insulin resistance. They may have had high testosterone, or probably maybe prolactin levels, something like that, that was stopping them, or thyroid problems, stopping them ovulating or having their periods. So that you can't see what's going on inside is what I'm trying to say. So you feel like you're being a failure by doing everything just because it's not showing up on the weight or the scales or by return periods. So this is actually a message to people that are watching though, guys. It's not me telling Shirin because she knows all this, but it's to everyone here. It's like, keep going, even though you might not be seeing those massive results that you want, but it's the non-scale victories or everything around it that's helping you get to your goal. So don't stop is what I'm trying to say with that. Cool. So I can see some questions coming in just now. We will get to them at the end, guys. So if you do have questions, I'll pop in here. please get them down into the chat there, and we'll ask Shirin at the end, and she'll be happy to stay on and answer your questions. So we do have a couple more questions for Shirin. Okay, just a few. Some of them will be quick to answer, and some of them might need a bit more in depth. So a lot of women do struggle as well with, I get asked this a lot, when is the best timing for when you're trying to conceive, you've been given everything, or you're in your fertility window, when is the best time to have intercourse as well? Because I hear different variations online.
Yeah, so I think understanding what your cycle length is really important. And so what I would say is, again, knowing if your cycles are 21 days or 28 days or 32 days, because it goes back to counting back that 13 to 15 days. We talked about how that luteal phase is what is fixed.
Yeah.
So that's why somebody who has a 28-day cycle likely ovulates around day 13 to 15, around day 14.
Okay.
But somebody who has a 30-day cycle will ovulate 2 days later than that. And same with a 35-day cycle, you have to count back that 14 days. So that's when you want to have intercourse, is generally in the 5 to 6 days leading up to the day of ovulation, either every day or every other day. If you are somebody who can't predict your cycles, then I would say having intercourse every 2 to 3 days is ideal, because many people who don't necessarily know when they're ovulating will catch ovulation that way. Yeah.
Okay, that's right, because some people say, oh, you can't have sex every day because, you know, it might affect the sperm. Other people say, do have sex every day. So it's, you know, you hear different stories, but I'm more inclined to listen to MD Dr. Shirin, because she knows what she's talking about. Perfect. So, okay, how can a male partner support this process too? Because I like what you said way back in the beginning of different factors. One of them was male factor. A lot of women, we'd all put on, we're not getting pregnant because it's my fault. I've got PCOS, I'm not ovulating, or even miscarriages, it's our fault, and it's not. So what can the male partners do to help support their partners?
Yeah, absolutely. So by the time people come and see me, I will typically do a semen analysis. And I generally suggest, even in people who know that they have PCOS, aren't ovulating, and are just going to start to try some ovulation induction, I still talk to them about maybe even just doing a semen analysis at the beginning, so that you know whether you're going to struggle at all with just intercourse at home. And so that's one thing. And then in terms of the other things, like just improving male fertility, it's all the same things that we talk about with females. Like it's the same diet, exercise, sleep, stress reduction. And for males specifically, in terms of vitamins, like one of the things that's been studied to help improve sperm quality are a group of antioxidant vitamins. And so the antioxidant vitamins, they haven't been studied individually. There aren't great studies on things individually. And so it's kind of a cocktail of things. It's like L-carnitine, lycopene, I think NAC is in there. There's a whole bunch of like things thrown into this sperm vitamin, which is antioxidant vitamin. It's not something that patients or people have to be on. I'm very mindful that vitamins can be expensive, supplements are expensive, and so I really only direct that to people who have poor sperm quality when I've tested it. But it's an option when people say, what else can we do? You know, we have the finances to afford the vitamins every month, then that's another thing they could try. And then for males, the other thing that we talk about is avoiding heat, actually. So I see a question here about saunas, and the truth is that heat does actually affect sperm production in the testes. And so avoiding saunas, hot tubs, seat heaters are a big one, especially here in Canada during the winter. People who drive for a living, those are things that are actually not good for sperm health. Yeah, and so that's kind of one aspect. And then the other things are smoking, alcohol, less so. Alcohol has more of an impact on the ability to have an erection or the ability to have a reasonable libido, rather than actually an impact on sperm. And then the other big one that people don't often think about is cannabis, actually. And cannabis stays in your system for up to 4 weeks after use and has significant impacts on fertilization and the ability of the sperm to interact with the egg. So these are all the things that I talk about in terms of improving male fertility overall, as kind of a general education with my patients.
Good. It all just makes sense, but it's just what I was trying to hit home for everyone as well. It's just we can't help it as women, but just think it's all our responsibility to get pregnant, and because everything to do with the pill, or even when we maybe miscarry, it's all our fault. So, but just one supplement I get asked a lot actually about, Shirin, is maybe about your take on it, is CoQ10. I only advise this sometimes, especially for men or egg quality, because I know the research isn't really there. But what's your take on CoQ10?
Yeah, I would agree with you. Like, it's hard to read the research again.
Mm-hmm.
And the challenging thing, like the way that CoQ10 was studied, if we think about it as a use in IVF to improve egg quality, the challenge is every time you do a cycle, it's a new cohort of eggs.
Yeah.
So we don't know if it was really the supplement or just a difference in month, difference in egg quality.
True.
I don't think it's harmful.
Yeah.
We don't, so I think it's okay. I usually tell people to stop as well if they become pregnant as well. And I think all of the whole supplement world, I would say if finances are an issue, the ones I focus on are vitamin D and folic acid and iron if you're low. And then in the dream world where you are affording different things and it's not a break on your bank,
Mm-hmm.
I think that those things are reasonable, like CoQ10, inositol, NAC, like they're not harmful, if that makes sense.
No, perfect sense. Absolutely. It's just you'll know how it is. It's like people want to know about the supplements first of all, because it's like we think in this day and age that it's the magic pill. We want to take something to make everything better. Whereas in reality, it's what we're talking about, the protein, the exercise, the sleep, the stress. So it's about doing that in conjunction with the supplements to supplement. This is what I talk about all the time. I do get to some women. Some women do hear it, but some women, no, just tell me about the supplement. I'm like, I can, try. Okay, just a couple more questions, guys. Like I say, please do get your questions in there and we'll be able to answer them at the end. Okay, so I find most women, just what I'm talking about, I find most women want to take supplements to help, but we know way more is involved. I think we've actually answered this one actually, but it was one of the questions I had for you. What are the most important lifestyle factors to improve chances? So maybe just dialing down a little bit. I think you've just done it a bit there about the cannabis, the alcohol, but really the sleep and the stress and the protein. But is there anything else that you would want to, dial down into a little bit more?
No, I mean, I think like my overall message is fertility is a part of your health. And so, like we all know that a good diet, exercise, not smoking, not drinking, not using cannabis, all these things are not good for us. And we know that on some, subconscious level. And it's also not going to be good for fertility because it's just a part of your health. So I just say like, that's what I tell people is I just say fertility, there's nothing magic that you can do that's going to change your health immediately. And it's the same for fertility. And so it's about a process, a journey to becoming a healthier you. And fertility is one of the things that confronts people when they're younger.
Yeah.
And that they may not necessarily have thought about those things before. And so sometimes they're surprised that they may have to change what they were doing in their life because it's such a stark marker of health in some ways.
Yeah, I know. I kind of find when you're at school, you're kind of taught that, don't do this, you'll get pregnant so quick and things. It sort of puts that fear into you. So you're of that belief. So when you do try and you can't, you're like, what's wrong? Well, why can't I? So it's kind of that scare that you'll get to. But and I'd also just like to say, you'll probably agree with me, it takes time. This is what I try to help the women realize and learn, that you can't just take a supplement and you can't just change the way and then 2-3 weeks later, boom, everything's changed. You have to look to the future, 6 months, 8 months, and then because everything sadly works in cycles. We're helping your menstrual cycle and getting into a better place. So yeah, I think you'll agree. We're just so impatient in this day and age. I think that's the problem. We want things now.
Absolutely.
Instantaneous. So, right, we've got a couple of questions in there because that was the end of the questions. It's like, I know it's a wee podcast episode and I didn't want to bombard Shirin with loads of questions, but fertility is a massive topic. There's so much that we could have gone down, but hopefully this has sort of served to answer the basics for you on your fertility journey. But we will get to these questions and I'll just go and double check on the actual live itself on my profile, guys, to see that there's not any more. Okay, there might be a few more questions there. No, there's not. They've all come through. So, okay, so what is your opinion on metformin? I do get asked this a lot. I'm going to admit I don't like it. I've personally taken it, and you're the medical person. Please remember that, guys, everyone's listening. So, what do you think about metformin?
Yeah, I mean, I think it helps a lot of people. Like, I do think people find it to be very useful. I think it's kind of nice, actually, to have something that's non-hormonal. We do actually find infertility specifically, metformin helps to improve response to specific ovulation induction agents such as letrozole, such as Clomid, improve response in IVF cycles, prevents ovarian hyperstimulation syndrome, which is something that can happen in people with PCOS who are undergoing IVF. So it's actually, even if just for a short period of time while patients are under the care of a fertility specialist, metformin can be a really useful medication in that respect. Now, that being said, I know that metformin causes some unpleasant side effects, like diarrhea, nausea, and those are not pleasant. And it's also really hard because you often have to take metformin 3 times a day, which is challenging for anybody to kind of have to remember to take this pill all the time. And so I recognize those things. And so when I speak to people about it, I talk about it in the context of, maybe we'll just use it while you're trying to conceive now in order to help improve your response to make things better for you while you're under my care type of thing. And I otherwise, I would say a lot of the side effects do also resolve with use. So most people find it, it's a whole month that you might feel unwell for, but then people feel fine kind of on the long term. So again, I think it's a tool in the box. I don't think it's like a necessary thing for everybody. It's just another thing to try, and it's nice to have another option for women in women's health.
I do agree, even though I say I'm not a fan. What the problem being with metformin for some women is that they'll take it, have the really bad side effects, but they're not told how to change their diet. So they'll still be taking it with the processed food, the really bad foods that they're before. And obviously this is going to have an effect on the side effects. So this might give you that impression that metformin is not good, but really it could be that your diet isn't that great. So that was one of them. Right, we'll get to one here. I think we had Sophie had said, okay, just quickly, because we have talked about letrozole, but what's the views on letrozole versus Clomid? Because I know both have sort of similar actions, but they're different.
Yeah, so I mean, letrozole is much more easily available nowadays because Clomid has stopped really being produced, so it has to be made in compounding pharmacies, at least where I am. Letrozole is, in all of the head-to-head studies, letrozole, although it's used off-label, the company has not undergone processes to make it on-label. It's used off-label in PCOS. In kind of head-to-head studies, letrozole performs better than Clomid. It also is better for patients with PCOS in order to create only one follicle rather than multiple follicles. Now, we do use higher doses sometimes if our goal is multiple follicles, which is sometimes the goal. But I find that it's better at single follicular development compared to Clomid, which is good because having twins or triplets is a harder pregnancy and there are more complications for both the mother and the children. And then the other part of things is that Clomid actually can thin the uterine lining. So it has other effects which are not ideal. And so you kind of have to play around with the dose of Clomid to make sure that it's high enough that you're able to get a single follicular development and not multiple, and low enough that you're not affecting the uterine lining. So it's a little bit more finicky. And I think that's part of why, other than the lack of production, that a lot of us have moved towards using letrozole. Now, in the clinic that I currently work at, we have the availability of both, and we still prefer to use letrozole, but sometimes people need Clomid. So it's still, again, just another tool. Letrozole is what we use more commonly. And if people aren't responding, then we may move to Clomid, maybe because it works through a different pathway. So maybe a different pathway may be better for people.
Okay, that's actually interesting. It's like how different countries, because in the UK, it's still quite largely known to give Clomid. This is the first thing that you'll be given before letrozole. Some doctors are even quite resistant to give. I think it's probably because it's the off-label thing. They're quite resistant to give letrozole. So differences there. But so yeah, really good answer. Okay, just quickly about testosterone. This one here from Kayla, she's been told her testosterone was too high at 2.4. So just really, in your opinion, how would you advise women to lower testosterone coming into your clinic?
Yeah, it's not a single thing that you can do. It's working on all those things that we've talked about, because it's high because of PCOS in general. It's not high because you're
Yes.
overproducing testosterone, or you're
Yeah.
producing not enough SHBG, whatever it is. It's
Mhm.
not a single thing to kind of reverse. It's all just part of the same group of things. Working on diet, exercise, sleep, stress reduction, all those things together will help overall to bring these levels down. And it may not, the other thing I warn people is that it may not bring things down on that you can visualize on blood work. Like your testosterone may always be marked as high, and that's part of why sometimes people get told you have PCOS, you don't have PCOS, you have PCOS, you don't
Mhm.
have PCOS,
Okay.
because sometimes it'll be high on blood work and then it'll go away, and then people say, oh, you don't have PCOS anymore. That's not really true. You do still have PCOS,
Mhm.
and that's why it's also okay if the testosterone just remains high. It's just part of the pathophysiological process. So
Mhm.
I don't get too concerned about specific numbers and trying to bring
Yeah.
it down very specifically.
Good. I'm the same with sort of testosterone like that, because we also had one here. I mean, I actually look at SHBG when women comes into me to see their numbers, and when it's low and their testosterone is high, but it's the same advice I give them. Exercise, their diet, like coffee is actually quite good for things like that. So just I think it would be the same for you, what you've just said about you to balance these out, but it would still mean that you've got PCOS, but it would just mean your symptoms are a lot better. I think, do you need to add anything to that one?
No, again, I wouldn't focus on SHBG. You're right, it is low in PCOS, but there's
Mhm.
no like specific strategy for that
Mhm.
alone to increase it. It's just part of everything else that you do to manage PCOS.
Yeah. Mhm.
Yeah.
Yeah, I agree. With this one here, it can probably go down a whole rabbit hole, but just sort of we can answer it quickly. It's like with the products and the disrupting endocrines, really. So someone who works in that sort of environment, surrounded by it all day, what would you advise?
Yeah, I mean, it's really challenging, right, to limit our exposure to beauty products all the time.
Yeah.
And it's especially hard when that's part of your job and what you do. Um,
Hmm.
I would say it's probably not realistic to say to change jobs, right? Because that's what you were trained to do and it's what you
Yeah.
enjoy doing. And so thinking about the ways to protect yourself as much as possible, like wearing gloves, being in a well ventilated area, making sure that the things you're using are up to code, that you have the MRDS sheets around, that you can understand how they may impact your reproductive health,
Hmm.
considering like wearing whatever appropriate face covering is so that you're
Hmm.
not breathing it in if you're in a location that's not well ventilated.
Hmm.
Those would be the things that I would think about in terms of limiting your exposure as much as possible. In healthcare, we also have exposure to things, chemotherapeutic agents, etc., that we
Yes.
sometimes have to come in contact with. And so that's the way that we think about it as well, like protecting with gloves,
Yeah.
making sure that everything is disposed of properly, that it's not left lying around, that our area is
Yeah.
clean, things like that. So I would say focusing on what you can control is
Mhm.
probably the best way to do things, especially as we start to find out more and more. Like, I mean, 5 years ago, we weren't talking about aluminum free products, and now
No.
it's all over the place. So it's hard to even know what we're all exposed to at all times. And so just being as cautious as you can and safe
Yeah.
with what you're doing is probably the only way to go about it.
Yeah, I actually agree with you. We've got one more question, but I was just saying I agree with you in this, because it can actually increase your stress if you go out and you get anxious because you're trying to stay away from, what was it I seen on TikTok one day? Don't touch your till receipts because it's going to affect your PCOS. And if you went go into every shop trying not to touch receipts, and it would just cause so much anxiety and stress. We can't avoid everything. But it's what Shirin said, it's what you can control, especially if it's in your work environment, gloves, and keeping yourself safe that way. So yeah, hopefully that helped, Nikki. Right, just one more question, and it's about metformin again, but it is probably a good one. It is like, what would you do if someone really can't tolerate metformin? Do you have another option?
Yeah, absolutely. So, I mean, if it's very specifically because you have diabetes,
Hmm.
then there are certainly a whole host of other options, right? And that would be down kind of the diabetes pathway. If
Hmm.
it's in this kind of range where it's pre-diabetes or insulin resistance, sometimes we do use things, the semi-glutides or the sorry, I'm blanking on the name, Ozempic, Wegovy, like, those GLP-2 medications, it is used in people who have PCOS because it works through that same insulin pathway. And nowadays we're seeing it more and more, especially if people have a BMI over 26, have other comorbidities, then those are kind of indications for those medications. So I will say that I have not used those as much, and so I'm less comfortable, but certainly I've worked with many endocrinologists who have used it. And so that it depends what the goals are, because the other reason I don't use it is because you can't be on those medications when you're trying to conceive. So I'm a fertility doctor, so all my patients are generally trying to conceive, so I don't use it for that purpose. The other thing that people can use, the alternative, is inositol. And inositol and metformin have been compared head to head and have been found to have similar effects on kind of the insulin resistance pathway, and tends to be easier in terms of GI side effects for people. So sometimes I will ask people to take inositol if I think it's going to be helpful. Again, if it's not a medication, neither of them are things that you have to do, right? They're not, you can choose to do nothing. You can work on your exercise. As Nikki was talking about, there's other things that you can kind of do that will be helpful for you. So I don't think it's a necessary thing, but if I think somebody needs to take it for whatever reason, those are what I'll talk about.
Good. And I love that you keep coming back to, you don't need to take these things and you can just work on yourself. But it's just women, it's a patience thing again. We just want things now. But if you can get yourself into that mindset, because we don't want you being on medication and supplements forever. You want to be doing this naturally down the line. So you want to be getting your body prepared for it, not using the supplement. So right, 1 second. So let's just see. I don't want to be keeping you too much longer, Shirin. That is the thing. Okay, just one more, just about inositol, just quickly. When would you recommend increasing to 3 times a day? This is not something that I actually do, Angelina. So it's went to 3 times a day for inositol. I'll just see what I do. Normally it's 4 grams. The recommendation is you can split it 2 grams in the morning and 2 grams at night. Or you can typically take it 4 grams, but the recommendation is 2 grams twice daily. I think that would be the same for you, hopefully, Shirin.
Yeah, I don't really. I mean, you can split up the same dose 3 times a day if you feel better. Like it's all about what was studied, and so it's hard. Like there may be people who are increasing the dose. It's just that an increased amount hasn't been studied, and even the formulations that are on the market right now, we don't fully understand how they're done. So I'm less particular about how much you're taking, and less
I agree, but I'm kind of thinking maybe this, Angelina, are you thinking about berberine? Because berberine is typically taken in 500 milligram dosage. You can do that morning, afternoon and night, like metformin. That's what berberine is taken like. So I'm not sure if you're getting those two mixed up. Right, perfect, guys. Honestly, this has been so helpful. It has been, 1 second, I'll hide this one. It's been really good having Shirin on. And if you've got any questions for her, even after this, ask down below. Or I want you to go and find her on TikTok, guys. I have posted up a few things at advertising that I was going live, but I'll also put her profile into this live tonight under in the comments, so you can go and follow her, you can learn loads, you can comment on her videos and ask her some questions, and I'm sure Shirin will be happy to help you over on TikTok, because that's where I found her. I found Shirin on TikTok as well, so she's great. I have learned so much from Shirin over the last few months too, and that's why I've loved having her on my podcast, shall we call it. So do you all want to add anything for the lady, Shirin, or?
No, thank you very much for having me. And, I love talking to people about PCOS and reproductive health, and that's why I'm in the field. So happy to share my expertise.
Definitely. So it's been really awesome. But like I said, I just want to reiterate, guys, this is it's not medical advice tonight. We're just here to help you understand the processes and things about fertility. And again, Shirin is going to be more than happy. So if you do find her, I'll do it straight after this live here. I'll post it into the live comments to go over there and find her and give her a little follow, and you can learn way more about your fertility, because we're not taught enough about it. So this is where we're trying to help you learn and feel that you're not broken. You're not broken, guys. You really are not. So, right, we'll just close this out. So thanks so much. And then why don't you can show us some love. I can see the love coming through on my Facebook, but we don't see it here, sadly. I wish we did have all these emojis and things. So, but thanks so much, guys. I'm just ready to end it we can follow. We're getting more hosts on here, more guests rather. So come back and join us for that. So we'll speak to you later.